So it's a great pleasure to introduce the first speaker for this immunotherapy, toxicity and steroid use in older cancer patient webinar. It's Dr. Fabio Gomez, and he is a consultant medical oncologist at the Christie Hospital in Manchester in the United Kingdom. And he works within the lung cancer team and at the patient-centered research team. And he's also the director of the clinical outcomes at this cancer center unit. And he has a special interest in care of the older cancer patients. And he is also the vice chair of Young SIOG. So I will introduce the other speakers before each of their talks. So Fabio, the floor is yours.
Thanks, Martin. Let me share the slides. Is it working?
Yes, sorry.
Real, thank you. So yeah, thanks for the introduction. So yeah, I'll be talking about the role of the immunotherapy, in particular checkpoint inhibitors in older adults with cancer, and I'll keep an eye on time. Let me see, I'm moving. Okay, here are my disclosures. So I felt it would be good just to give a brief overview of what immunotherapy is, what checkpoint inhibitors are, because I'm expecting to have a mixed audience, just to bring us all into the same page. So immunotherapy is pretty much any treatment that would be manipulating our immune system to treat the cancer, and checkpoint inhibitors that I'm sure all of you have heard by now is one class of treatments within immunotherapy, and they've been quite successful. But it isn't the same thing. So there's a lot more to immunotherapy beyond checkpoint inhibitors. And when we think about checkpoint inhibitors, what we're talking are checkpoints within the T cells, which are a key element of the immune system, and then regulate and cascade a whole range of actions. And there are different checkpoints and there are different drugs, and we'll recognize some names on the side there. And basically, depending on the different checkpoints, we will have slightly different designs of drugs. And this has been a massive breakthrough. Started in terms of clinical impact, started mainly with melanoma, expanded to lung cancer, renal cancer, and so on. And currently, it's pretty much in every type of cancer almost. And the breakthrough was so significant that this led to a Nobel Prize. So it's quite impressive. And when we think about immunotherapy and we're thinking about checkpoints in particular, but not just, but when we think about that and we can put this in the context of older patients, there's been loads of discussion around the concept of that aging immune system and how made that impact how well the treatment work and how safe it is. So this whole concept of immunosenescence isn't just specific to the T cells. So it's the wider immune system, but it did raise and still raises some questions. And if we are manipulating this immune system and we are hopefully unleashing these T cells to cascade those reactions to tackle the cancer, there's a risk that by overactivating perhaps the immune system, at times we may have a wide range of side effects. And these are the so-called immune-related adverse events. And you'll see that throughout the presentation. And I'll focus very much, because in 10 minutes, of course, I wouldn't be able to cover everything. So I'll focus very much on the safety and the tolerability of this treatments. So the immune system is literally everywhere in our body. So therefore we can have side effects that would happen anywhere, any organ and any tissue. But there are quite a lot of specificities, and they're quite unique because we don't still fully understand the mechanism behind all the toxicities. We don't see a clear correlation with most of the checkpoint inhibitors between the dose and the toxicity, which is different from chemotherapy, where the higher the dose, the higher the toxicity. That's not the same thing. It's not a clear cut when we're thinking about immunotherapy with checkpoint inhibitors, and therefore there isn't that concept of the patient is having some side effects, let's reduce the dose. So there is no dose reduction. And when the side effects happen, they have quite a variable onset. Some may happen quite early on. Some can actually be quite delayed. And when they do happen, they can actually be quite prolonged in time. And even sometimes beyond, after we've stopped the treatment, they can still be having the side effect. And another important difference is when we think about chemotherapy, for example, patients are often treated for limited periods of time, but with immunotherapy, they might be treated for many, many months or even years if all goes well, which means that perhaps with immunotherapy, we need to think not just about those high-grade side effects that may have a huge acute impact on the patient, they might cause an admission, but also thinking about those lower grade, because if someone is going to have a lower grade side effect for years, that may actually be quite significant. And it's often a challenge to diagnose a lot of these adverse events. And then depending on the checkpoint we are inhibiting, as I was discussing in the beginning, they have slightly different profiles of side effects. Which side effects more prevalent when they happen is slightly different. And of course, that's what we do. If one works and the other one works, let's combine them. And as we start combining them, this becomes even more complex. But one thing that it's quite interesting to see is about 40% of the patients that have the side effects, they tend to have more than one. So often they come with a package of multiple side effects. So we need to be aware, if we find one, there might be other side effects there as well that we need to be on the lookout for. So the question is the treatment with these checkpoint inhibitors, is it well tolerated? Is it a walk in the park or not really? That's an important question. And to try to answer that, because by now there are so many trials, that what I did is I built this table, and this is just summarizing the incidence. This first row is summarizing the incidence of high-grade treatment-related adverse events. So these are grade 3 to 5, which means these are side effects that usually cause the admission of patients. They could be life-threatening or even kill the patient, sadly, because of the side effects. So high-grade side effects, and you can see with chemotherapy that would vary. Of course, it depends on the chemo, but in the range of 30 to 70%. Single agent, so giving just one checkpoint inhibitor, this could be around 10 to 30%. But once we start combining 2 checkpoint inhibitors or checkpoint inhibitors and chemotherapy, we can see that increases. And therefore, if we think about treatment discontinuation rate, it follows the same trend. But as I was saying, especially when we're thinking about checkpoint inhibitors, we need to think about the whole. So we need to think about even any grade side effects, because they may have an impact if the patients are going to have it for a long time. And as you can see here, overall, giving the patient a single agent checkpoint inhibitor seems to be, in terms of tolerability, better than the other options. But when we think about safety and we think about tolerability, we must think as well about quality of life. And I won't go into all of the details on this table, but basically this is an example of melanoma, and it's just showing us how comparing immunotherapy and chemotherapy, immunotherapy has a positive effect on quality of life. This is another example now from lung cancer, and you can see the curves here with the blue being immunotherapy and the red being chemotherapy. And the first graph is showing us that the time to deterioration of physical function of the patient seems to be longer. So it takes them longer to deteriorate whilst they are on treatment. And when we look at the second graph that is showing us the change compared to the baseline quality of life, you can see that actually with immunotherapy, not just it is sustaining the quality of life, but actually is improved throughout whilst they are on treatment, whilst we see the opposite with chemotherapy. But who are we actually treating in these trials? And these trials are often younger patients and overall much better in their health. And I was looking at the example of lung cancer, and if we look at the median age of patients that are being recruited into these trials, they are 10 years younger than the age of being diagnosed with lung cancer. So it's clearly a younger population and a fitter population. I doubt any have all those fit patients coming through the doors in our daily practice. So it is different. And we look at the data from these phase 3 trials, they may provide some data in terms of survival by age in the subgroup analysis, but they don't do the same really for safety. So I don't know if older patients were having more side effects or not. So there were some pooled analysis that pulled data from these randomized trials and looked at safety. And as you can see here, and of course with the caveat that we're looking at those with the performance status 0 and 1, so patients that are relatively well in themselves. And then we can't really see that those pooled analysis couldn't really see a clear difference that older patients were having more high-grade side effects. So the next question is, but are we correctly identifying older patients that have frailty? Because if the patient has frailty, they will likely be less likely actually to be able to cope with those side effects. And often, and we'll talk a little bit more about that later on, if the patients have side effects with immunotherapy, they are often given high-dose steroids for quite long periods of time, and that has a lot of implications as well, as we'll see. So we need to focus on real-world data, and that's, of course, the trials is a good starting point, but we need to get data, more data when we're looking at this subgroup of patients. And there was a nice publication that just came out with ASCO, looking at real-world outcomes from patients with immunotherapy in the UK. And this was a multi-center study looking at over 2,000 patients, and they got different categories of different age categories. So we would have patients over 75 years, 50 to 75, and under 50. And you can see, because they've included both patients getting just single agent immunotherapy or combinations, and you can see that as the patients got older, the likelihood of the clinicians offering them a combination of checkpoint inhibitors decreased. So only 3% of those over 75 were being offered a combination. And when they looked at any grade of toxicity, and they put in the same bag the single immunotherapy or checkpoint inhibitors or a combination, there wasn't any significant difference. But when they looked at just the single agents, they seemed to find that older patients might have been having more side effects from the treatment. But these weren't actually high-grade side effects. So these were the lower-grade side effects. So that's an important point. And the last thing that I wanted to raise is we need to think about slightly different study designs if we want to focus more on these older populations, because of course age on its own, it only takes us so far, and it doesn't define the patient. So we've developed, we ran this study here in Manchester so it was a prospective cohort study looking at the safety of checkpoint inhibitors in older cancer patients. And then we've recruited patients just for single agents, so patients that were being selected within the clinical practice to get a single agent checkpoint inhibitor for either lung cancer or melanoma. They would be recruited, and the primary endpoint was looking at that high-grade toxicity. But we've incorporated geriatric and frailty assessments. I won't have the time to go through all the details, but just to highlight some of the findings. So we enroll 140 patients, and these were patients that were going to go for immunotherapy. And immunotherapy, at least in the UK, and I assume in the majority of countries, is very much limited to patients that are relatively well. And we saw that about half of the patients failed, had a positive screening on the G8 tool. And then when the patients underwent the CGA, we can see that if we start on the top, we can see about 90% had significant comorbidities. They had polypharmacy, they have impacted activities of daily living, problems with nutrition. So over half of the patients with older patients that had the CGA had all these issues. So this is a population that clearly is a little bit more representative of what happens in daily practice. And what we found was that, again, and similar to the other studies, we couldn't find a significant difference in the incidence of high-grade toxicity, which is quite reassuring. And when we looked at, does frailty predict those who might have high-grade toxicity? It didn't, but perhaps with no surprise, it did predict those that didn't cope as well with immune-related side effects. So it is indeed important to go beyond the chronological age and add this extra layer when we're focusing on this group of patients. So my take-home messages, and I hope I'm relatively on time, there is an overall underrepresentation of older patients still on the trials. And although checkpoint inhibitors are here to stay, and they've clearly revolutionized how we treat a lot of the different cancer types, still there is that underrepresentation. So I think real-world data and pragmatic trials is important, and they will bring us a little bit more information. But overall, I think it's very fair to say that single agent checkpoint inhibitors, they're well tolerated, they maintain or even improve quality of life for older patients. So I would say they're a good match. I think perhaps the concern is when we go to newer combinations between multiple checkpoint inhibitors or checkpoint inhibitors and chemotherapy, where data is a little bit more limited. And we know there are more concerns with tolerability. That doesn't mean older patients shouldn't be getting it. I actually think they should, if they are fit for it and if they're properly assessed and supported for it. And therefore, the role of having geriatric assessments and all that support around them becomes even more crucial for these newer combinations. Thank you.
Thank you very much, Fabio, for this great overview. Everyone who has questions, please type them up in the chat, and then we'll go to the questions. But now I would like to introduce Dr. Dan Spakovic, who is an assistant professor in the Division of Medical Oncology and the Department of Biomedical Informatics at the Ohio State University Comprehensive Cancer Center, and then studies how to use the microbiome as a biomarker of cancer treatment responses and as a therapeutic target to improve treatment outcomes in older adults. And with his group, they support microbiome collection in clinical trials at the Ohio State University Comprehensive Cancer Center and across the United States. And they conduct trials that seek to modify the microbiome through dietary and other interventions and test for causality using preclinical models. So then the floor is yours.
Thank you very much. I would like to try to communicate three major points with this presentation. The first is that the microbiome is causally associated with response to immune checkpoint inhibitors, as we just got a nice introduction to. But then importantly for the context of this meeting, the microbiome changes with age, and older adults are more likely to benefit from microbiome modification than the general population. But it's still unclear the best way to do that. I'd like to comment on different ways that are being explored to optimize response to immune checkpoint inhibitors using the microbiome, which include things like fecal microbiota transplant, probiotics, diet, etc. And then give some concepts on how we might tailor this to older adults. And I put in a plug for what I think is, at least right now, a safe and actionable bet, which is to increase diet diversity and fiber intake and focus on that in older adults. So as an introduction to the microbiome, at some point I'm going to stop giving introductions because it'll just generally be known, but I'm continuing it for now. You are about 40 trillion cells, are human, but you have roughly as many microbial cells on your body. And they are much more genetically diverse than you are. So it's roughly 100-fold more gene types, which means that they can degrade greater variety of different carbohydrates and other polymers that you eat. They can make a variety of other molecules that you can't, and are generally influencing you in a bunch of ways that we're just starting to learn about. A unifying principle that I find useful to think about is, especially in the gut, which is the focus of this talk, because the gut seems to have the strongest interaction with the immune system. You can think of the gut as a selection mechanism enriching for certain microbes. So if you look at these pie charts, imagine, this is sort of mock data, but imagine that these are the ratios, the relative abundances of different phyla of bacteria, for example. In the environment, you've got a lot, especially of this yellow that's just around in the soil and on surfaces, but the gut has a very different ratio. It wants that yellow to be much smaller. And the increase or the abundance of these taxa looking more like the environment than what is a typical gut is a sign of dysbiosis and associated with many different diseases. And in fact, I said these are mock data, but this is from a summary of a variety of different things. This is proteobacteria. It tends to be highly enriched. These are Bacteroidetes and firmicutes that you may have heard about. But the point is that this is a general principle by which the gut is selecting for different sets of microbes. And I mentioned that this was correlated with a lot of different diseases, but I want to push on this a little bit more for cancer. So I'm going to start with how it is correlated with cancer outcomes, but then demonstrate the causal mechanism here. So in 2018, there were several papers that came out showing that you could take someone's poop before they started treatment with immune checkpoint inhibitors and say whether or not they were going to respond. And fundamentally, I find that result to be pretty mind-blowing still as I talk about it. I'll just show some of the data here. These are both two different papers from the same issue of Science. They're both principal coordinate analyses, so they take a high dimensional data set and just squish it onto a single point. So each of these points is a person's stool, a summary of all of the abundances of all of the microbes there. And so you take each person, you smush all their microbes into a single point, and then you color it by whether or not that person later went on to respond to immunotherapy or not. The observation is that if you color this, it naturally forms these two clusters in this unsupervised way. You can therefore say that you could predict whether or not someone is likely to be a non-responder to immunotherapy or responder just based on their poop before the start of treatment. And that was borne out in a couple different data sets. One of the papers went on further to show a causal relationship in preclinical models. Now, the experiment here is to take a mouse model who has cancer and transfer in human stool. So this is poop from a person who did not respond to immunotherapy before they started treatment. And you can see even in the context of PD-1, that tumor does not get smaller than the control mouse with the just IgG control. Conversely, if you give that mouse the poop from a person who did respond to immunotherapy, now you can transfer that phenotype. So just by transferring stool, that mouse will start responding to immunotherapy and recapitulate the phenotype found in the person. Moreover, you can do it with a single microbe. So now what I'm going to show you on the y-axis here is the size of different tumors. This first column is in the context of non-responder stool treated with PD-1. It's a replicate of this experiment here, now shown over many different mice, measuring the tumors of each. Each of this, you can imagine, is the measurement of tumor volume here. So this is the size of a tumor treated with PD-1 in the context of non-responder stool. If you skip over to this group over here now, this is taking that non-responder stool and adding in just a single organism called Akkermansia muciniphila. And in the context of non-responder plus Akkermansia, the tumor is smaller. So this demonstrates a causal mechanism, at least in the context of preclinical models. More recently, it's been shown that you can take individuals who are resistant, whose cancers are resistant to treatment with immune checkpoint inhibitors, and alter their microbiome through a fecal microbiota transplant, and in some cases improve response. So this is two different papers, both quite recent. Here colored by the donor, this is a time scale and the size, the change in tumor from baseline. And you can see that in the context of donor number 1, 3 individuals who got that same donor's stool had improved response even after having progressed on immune checkpoint inhibitors. Similarly, even though the colors have altered here in a way that's somewhat confusing, the same pattern was observed here with a couple different donors. There's a few points that I think are relevant here. One is that, even in the context of immune checkpoint inhibitor resistance, you can modify outcomes, but also that the donor is important. There's a lot we don't know about that. These donors were selected in both cases by individuals who had shown a complete response for greater than a year. And the fact that that did not confer to all of these other people is confusing. And I propose is even more confusing in the context of older adults. And that's because the older adult microbiome changes with age. So this is a bit of a busy figure, but I'm going to try to walk you through it. This was our attempt a few years ago, or I guess we made it for you a few years ago. It came out this year. To summarize all of the work that's gone into not only who responds to immunotherapy and which microbes are associated with that, but also whether or not those are associated with younger or older people. So now on the part over here, you see all these different taxa. These are genera of different bacteria. And then whether or not they're associated with non-responders to immune checkpoint inhibitors, response, or unknown or mixed results. And then here we have similarly breaking it down by younger groups, older adults, or unknown or mixed. And so the context here is if you follow that Akkermansia I've shown you before, that is associated with response. So this blue line goes over to the response group, but it's also been enriched, shown in the literature in several studies to be enriched in younger individuals. So that's why this little waterfall goes over to the younger individuals. And what you'll see, and although it's not totally clear here, is that several of these that have shown the strongest causal mechanisms, causal relationships, including Akkermansia, but also Bifidobacterium and also Ruminococcus, are all associated with response, but also with younger adults. And in fact, there's a fairly large contingent of non-responder type microbes that are enriched in older adults, and quite a large number of microbes that are unknown, in part because this is an underrepresented group in the context of clinical trials, as Fabio was mentioning before. So this indicates that older adults are likely to benefit, as an older adult is more likely to look like a non-responder to immune checkpoint inhibitors than sort of a typical younger individual. So how might we change their microbiome? A recent review, I think, did a really nice job of summarizing a variety of different ways and then their challenges and advantages. There's a concept of targeted modulation, which you could do through a variety of different approaches, including like phage therapy or adding in other sorts of molecules. But there's not a lot known about that. You can imagine diet and lifestyle, which I think is, as I'm alluded to before, our personal favorite. But it's unclear if the effect will be sufficient, and I think that remains true today. There's also a fecal microbiome transplant. It's difficult to scale. It has shown effects, but there's a lot that's not known about how safe it is and in what cases it's appropriate and which donors really contain the right organisms. I like the idea of defined consortia. We're still working out what this is likely to entail, but then there's this pre and postbiotics. So these are different molecules here. So instead of the prebiotic type targeted modulation, this is just adding in either molecules that increase the abundance of an organism or those molecules that are made by organisms. That's the postbiotics thing. I'm going to try to hurry through the last couple slides here really quickly. So I just want to summarize the work that's going on to date. There, as Fabio was mentioning before, few studies that focus on older adults. And here I'm talking specifically about the clinical trials that are trying to modify the microbiome to improve cancer outcomes. So we haven't reviewed this all very recently, but at the time there was something like 30 trials trying to modify the microbiome, of which 5 of them focused on older adults and 3 of them were involved in our institution. So there wasn't a lot outside of OSU. Probiotics may be bad. This is something that I really want to emphasize here. So this hasn't been published, but an abstract that came out last year at AACR showed, or at least showed to the level of criticism of an abstract, that over-the-counter probiotics were associated with lower survival. However, there are 2 clinical trials going on right now giving a bifidobacterium probiotic. We haven't seen any data from those yet, to my knowledge. But we'll see what happens. And the concept here is that what seems to be important is diversity, and probiotics are decreasing diversity. That's been shown in a variety of different ways. It's possible if you're giving the right microbe, that's okay. You can handle this decrease in diversity. I'd be happy to talk about diversity as a general framework for thinking about these things at length. But in general, it's unclear, and I warrant caution, based on some of these results. But I think diet is a fairly safe bet. In a few different studies of older adults, it was shown that diverse and fiber-rich diets were associated not only with microbiome diversity, but also health and the absence of frailty and things like that. So even if it doesn't help in the context of immunotherapy, it's likely to benefit people, but it's probably going to benefit their immunotherapy outcomes as well. And again, in an abstract, this is a pretty rapidly evolving field, a higher fiber diet was associated with improved survival. So we'll see if that pans out in the final publications. So there is one study I just want to highlight that is trying to identify whether dietary intervention can improve response to immunotherapy in older adults. And the last patient of receiving this just finished, I guess, a week or so ago. So we're actively working on generating the rest of the data here. So this is giving a berry beverage that's high in these dietary polyphenols, which we expect to increase the abundance of this one organism, Akkermansia, that I keep mentioning. One thing that's a moment of caution is that concomitant medications are likely to affect outcomes as well, and we think that's happening through the microbiome in some, but not all cases. Here I'm showing the effect of antibiotics taken right around the time of the start of immunotherapy. And so the concept here is that antibiotics aren't likely to affect the tumor, but they do affect your microbiome, and people who are prescribed antibiotics die sooner than those who were not prescribed antibiotics. But these are retrospective data. This is not randomly assigned to get antibiotics or not, so take those caveats, of course. But it's not just in in melanoma, for example, and we see it in a lot of different cancers. And we see these effects through a variety of different drugs that are thought to affect the microbiome, including some new results on proton pump inhibitors that we just presented at ASCO. So in conclusion, many different lifestyle factors affect your gut health, your biological age, and your microbes. All of these things we think are strongly interacting in a way that affects response to immunotherapy, and they should be taken into account, especially with older adults. So thank you very much.
Thank you, Dan, for this very interesting overview. Again, if you have questions for Dan, please put them in the chat, and then we'll get to them after all 4 talks. And so it's a great pleasure to introduce Darren Walls, who is the Senior Pharmacist in Cancer Services in the University Hospital Waterford for both oncology and hematology. And his research interests include geriatric oncology, chemotherapy-induced nausea and vomiting, and polypharmacy in cancer patients. So Darren, the floor is yours.
Thank you, Martine, and thanks, Dan and Fabio, for your presentations. It's made for really great listening so far. So hopefully I can continue on the good trend. So as Martine said, my name is Darren Walsh. I'm a Senior Pharmacist for Cancer Services in University Hospital Waterford in the southeast of Ireland. And that includes the hospital in Waterford, which is the cancer centre, but also we have 3 associated hospitals as well in Kilkenny, Wexford and Tipperary in the region. And in University Hospital Waterford as well, we have the first in Ireland geriatric oncology assessment and liaison clinic, the Gold Clinic, which is run by Dr. Anne Horgan, an oncologist here in the southeast of Ireland. So I'll try and keep it short and sweet and keep it quite simple, and just give a quick overview firstly of corticosteroid pharmacology, because in order to understand why we might be getting adverse events to corticosteroids if used to treat adverse events to immuno-oncology agents, we first need to understand how corticosteroids actually work. So they are synthesized in the adrenal cortex, and there's 2 different types of corticosteroids. We have glucocorticoids, such as hydrocortisone, and they are under regulatory control from the hypothalamus and the pituitary gland. And we also have mineralocorticoids, such as aldosterone, and they exert their main actions on fluid and electrolyte balance. So endogenous corticosteroids are produced by the adrenal gland in a diurnal and circadian pattern every 24 hours, and they're at their highest levels within the body in the early morning between 6 and 8 a.m. when we're just about to wake up, and at the lowest levels at night time when we're asleep. And that plays a role in terms of the advice for when to administer or when a patient should take corticosteroids, synthetic corticosteroids that we give them as a drug. As well as that, under non-stressed conditions, the body will produce the equivalent of about 20 milligrams of cortisol a day. In physiological or mentally stressed situations, the body can go up to somewhere between 150 and 200 milligrams of cortisol a day. So you get this massive upregulation of cortisol production in the body in a stressed state. So that's very important when we're trying to identify people who are experiencing toxicity to immune checkpoint inhibitors, that they might actually be producing an awful lot more natural physiological corticosteroids or cortisol at the time. So therefore, we could be, by administering high doses of corticosteroids, we could be adding to that as opposed to from a baseline, a non-stress baseline, because these patients could be under physiological and of course mental stress if they are experiencing a grade 3 or 4 adverse events to immune checkpoint inhibitors. So then when we look at the actions of glucocorticoids, they have potent anti-inflammatory immunosuppressive effects, partly through the inhibition of the release of various cytokines, and I'll go into that in a little bit more detail in a minute. They also have profound metabolic effects on blood glucose, glycogen deposition, protein breakdown, lipolysis, and calcium storage. So we can see here that glucocorticoids exhibit their actions on a broad range of tissues and cell types. So therefore, when you use glucocorticoids in the older population, you are open to adverse drug events in a broad range of tissues and organ types as well. and different parts of the body. They also facilitate the actions of other endogenous substances that affect cardiovascular, renal, skeletal, and CNS function. So therefore, we can see drug-drug interactions or other pharmacodynamic actions that will lead to knock-on effects and knock-on adverse events down the line. And it's worth also noting that pharmacological dosing of corticosteroids can often lead to a significant and undesirable proliferation of these effects. And that's what can lead sometimes to prolonged ADRs that we might see not directly after the administration of the corticosteroid, but further down the line. In terms of the mineralocorticoid actions then, they affect fluid and electrolyte balance. So they play a role in the regulation of that by enhancing the sodium reabsorption in the kidney, and they also enhance the renal excretion of potassium and hydrogen. So they play a key role in this very fine balance, and that can be really important in terms of people who have got issues with their renal function as well. I suppose in order to understand then synthetic corticosteroids, the pharmacology of them, we have to look at their mechanism of action, and they diffuse across the cell membrane into the cell, and they bind to the glucocorticoid receptor, and that just basically inhibits transcriptional processes. And in effect, what that can lead to is it can lead to a decrease in pro-inflammatory cells such as macrophages, dendritic cells, but also as well it can lead to the inhibition of important agents such as cyclooxygenase, which it's postulated that plays a key role as well in some of the adverse events of corticosteroids when they're used over a prolonged period of time, or also, which is very important to note, in the geriatric oncology population, without looking at immune checkpoint inhibitors, when we use high pulse dose of steroids like we do in myeloma or in treatments for non-Hodgkin's lymphoma. So in the general geriatric oncology population, not just those on immune checkpoint inhibitors, that mechanism of action, and therefore the mechanisms of adverse drug events is really important to bear in mind, and a really important consideration for patients who are undergoing treatment for those conditions too. So just, I suppose, it's always important as well to compare and contrast corticosteroids. This is a handy little table just that outlines the differences, the pharmacokinetic differences between some of the most commonly used ones. So for example, if we look at the anti-inflammatory potency relative to cortisol, hydrocortisone has is equivalent, whereas dexamethasone is a much more potent corticosteroid, and prednisolone is somewhere in between. So the approximate equivalent dose then, as you can see, there's quite some similar efficacy there. And what this shows us is that say dexamethasone is primarily glucocorticoid versus hydrocortisone and prednisolone certainly have more mineralocorticoid tendencies than dexamethasone. You can see that in the sodium retaining potency. So we know when we're using certain corticosteroids, certainly we can expect different adverse events or different actions as well if we're looking to affect those actions by using different corticosteroids in different situations. Something that's quite important as well, especially when we are talking about the gut, just as Dan was touching on, but also the oral bioavailability of the pharmaceutical agent. So you see that hydrocortisone has a 96% oral bioavailability, so it's almost equivalent to an IV dose when you give oral hydrocortisone. Just the onset of action is about an hour later. Whereas with prednisolone and dexamethasone, it's about the oral bioavailability is about 70 to 80% of hydrocortisone or cortisol. So, or the IV equivalent, my apologies. So what we see there is sometimes in an elderly patient, if we want to decrease that peak plasma concentration that we get with an IV dose, and we want to give slightly less, sometimes just switching to the PO, the oral equivalent, can actually be quite favorable if the patient is tolerating oral drug. That can actually play to our benefit as well. So what we see here is by not just deciding on using a corticosteroid in a geriatric oncology patient, and especially for, say, the tapering phase after a patient has had intervention to an immune checkpoint inhibitor adverse event, we can almost manipulate the corticosteroid of choice to exert the effect that we want, depending on the location of the adverse drug event and how that's manifesting in the patient. So even with these older drugs, we can still, in a way, use the characteristics of those drugs to have, in some sense, a targeted therapy. So it's also worth bearing in mind when we are talking about geriatric oncology patients who are using these drugs, the age-related changes in pharmacology that we can expect. So, for example, drug absorption, there's quite low-grade evidence for age-related changes in drug absorption when a drug is taken orally. But something that we need to consider in geriatric oncology patients, depending on their indication and comorbidities, is if they might have had GI surgery, which might affect the length of gut available to absorb a drug. But also with drug absorption, you also need to take into account other medication that might affect that too. First pass metabolism, bioavailability, you get a decrease in first pass metabolism with advancing age. And first pass metabolism is the mechanism by which prednisone is converted to prednisolone. So if you work in a center that uses prednisone, as patients get older and their first pass metabolism decreases, the conversion from the inactive prednisone to the active form of prednisolone will actually decrease and slow down as well. Distribution, it's important to note in the geriatric oncology population that distribution decreases. As you get older, you get a decrease in total body water and lean body mass and an increase in body fat. So body composition can change quite a bit in the older population. But in terms of corticosteroids, this isn't as relevant because they tend to rapidly distribute throughout the body, and uptake into cells tends to not be much of an issue. And then elimination, age-related reduction in hepatic and renal drug elimination. It can prolong the drug half-life and increase then the exposure to drug. And we see that in particular in corticosteroids with renal elimination, because, as I said, not only is the mineralocorticoid effect of a corticosteroid agent having a heavy influence on physiological things that are happening within the body in the renal system, but also too, the majority of these drugs are primarily eliminated by the renal route. So if we have impaired renal function, it can disturb the action of the corticosteroid, but also prolong the exposure of the patient to the dose that you're giving them. So it's always worth looking at someone's renal function and considering that it might be worth giving them a lower dose of corticosteroid, or if they are a frail individual and have decreased renal function, we might try and use as low a dose as possible for a shorter time as possible. So in terms of managing immune-related adverse events in patients treated with immune checkpoint inhibitors, the ASCO guidelines are quite simple to follow. We find them quite useful in our practice. So with a grade 2 toxicity, you may treat with corticosteroids, but with a grade 3 to 4 toxicity, you really want to go in hard with prednisolone or methylprednisolone, and it's 1 to 2 mg per kg per day for at least 4 to 6 weeks. So with that level of corticosteroid involvement, you're really looking at you need to go in with that level of steroid to control the adverse event and to get the patient hopefully fit to go back on their immune checkpoint inhibitor. But that duration and that length of treatment with prednisolone and methylpred will also need a weaning period. And when we have that level of treatment with corticosteroids, as I'm sure Michelle will touch on in her talk, that will require some ancillary medication as well. And then you're looking at really trying to optimize that patient's medication to make sure that they don't get opportunistic infection or suffer other adverse events to the corticosteroid. We also need to make adjustments for older adults who experience immune-related adverse events with these immune checkpoint inhibitors. We need to take a holistic MDT approach, and the approach taken will depend on multiple factors, including but not limited to drug-drug interactions, like I've mentioned already, and the patient's liver function test and their urea and electrolyte counts as well. So we need to keep a close eye on those just to check that there aren't any massive changes in the patient's biochemistry, and also any comorbidities that they have. But we also need to assess the patient tolerability as they go through this management of the toxicity. So we need to see if the patient is tolerating the treatment, and then if they are struggling, we need to be able to adapt and make changes and intervene if needed. So then where do I come in at the role of the pharmacist? I think what's important is trying to clearly identify durations of treatments and clarify the overall treatment plan, especially if the patient is to recommence an immune checkpoint inhibitor, because we want the patient to recover in a time frame that allows them to recommence the immune checkpoint inhibitor. And in order to do that, we need to get them down to a dose of corticosteroid that will facilitate that. It's also worth performing a comprehensive drug-drug interaction check to ensure corticosteroid treatment will not create further complications. Patients can be on a multitude of drugs that can interact with with corticosteroids, and some of the more common ones that you might see in the geriatric population are ACE inhibitors and also anti-diabetic agents. So their effectiveness can be decreased when used in combination with corticosteroids, particularly long-term high-dose corticosteroids. But also estrogens, if a patient is on an estrogen therapy, we can see an increased effect of the corticosteroid then. So you might want to go with a decreased dose if the patient is also on an estrogen. And also, I really enjoyed Dan's slide where it showed drugs that have an effect on the gut microbiome, because we see from a pharmacological perspective as well, some similar agents that also have that effect. So as I mentioned earlier, corticosteroids inhibit the production of cyclooxygenase, or COX, COX-1 and 2 as they're more commonly known in pharmacology, and also non-steroidal anti-inflammatories can do that as well. And we try and avoid non-steroidal anti-inflammatories in older patients anyway, because of other complications. But that's a really important one, because it can actually decrease the production of secretions in the gut, and that can remove the protective layer, that can increase the risk of GI bleeds. And especially depending on the cancer diagnosis that the patient have, they're likely to be already at an increased risk of GI bleed. So that's a really important one as well. And there are a multitude of drug-drug interactions. So what we want to do is use appropriate prescribing techniques such as stop-start, which we want to optimize the patient's medication in this population, especially when an ADR is experienced, because we want them to recover as quickly as possible. And what we don't want to do is add in treatments for the ADR that will only lead to more consequences. And finally, we want to identify additional monitoring that may be required for a patient on corticosteroids that might again identify issues sooner before they become problematic. So thank you.
Thank you very much, Darren, for that great overview. If you have questions for Darren, please put them in the chat, and then we'll get to them after. And then it's a great pleasure to introduce Michelle Hanan, who is an advanced nurse practitioner in geriatric oncology, and she's coordinating the geriatric assessment and liaison clinic within the medical oncology department at the University Hospital in Waterford, Ireland. And she also has a special interest in unmet needs of older adults with cancer and developing educational opportunities for oncology nurses. Michelle, the floor is yours.
Hi, how are you, Martine? Hi, everybody. So I'm just going to talk about considerations for older cancer patients and receiving corticosteroids. So the incidence of immune-related adverse events ranges from anything from 15 to 90% in the literature. More common with the combination therapies, less common with the monotherapies. Data varies amongst the trials. And once again, older adults seem to be underrepresented in terms of the diversity of the population included. Corticosteroids are frequently utilised in oncology practice. We use them as antiemetics, as pre-meds, pain, for anorexia, amongst other issues. I suppose they also are the go-to drug for treating immune-related adverse events. As you can see from the table below, corticosteroids are also present challenges in terms of their toxicity profile, particularly for older adults who may already have pre-existing comorbidities. So it is important that we consider the risk-benefit ratios when we are prescribing corticosteroids. Some pre-treatment considerations is to use the lowest dose for the shortest amount of time to achieve the treatment goal. And we need to look at and manage pre-existing conditions, for example, diabetes, hypertension, and high cholesterol. Closely monitor the patient for adverse events, and should they occur, initiate interventions. Patient and caregiver education is also very important in terms of medication safety and adherence. For example, education on the rationale for therapy, if pre-existing comorbidities, educate the patient around the possible signs and symptoms of an exacerbation of a coexisting condition, but also to advise the patient or the family caregiver not to stop the steroids abruptly, as this can increase the risk of adrenal insufficiency and adrenal suppression. So ensure that we give clear written and verbal instruction to the patients around how to take corticosteroids, but also around the tapering of them when that does happen. And patients can be advised to carry a steroid alert card if required also. These are some considerations for patients on corticosteroids. It's a general list, it's not exhaustive, but these are common issues that we would see in our day-to-day practice when we encounter with older adults. So the first three I'll speak about in a little bit more detail, but in the interest of time, just to go through some of these briefly. So in terms of diabetes, those at particular risk are those that have already established diabetes or those with a borderline diagnosis. But those that don't have any diagnosis can also be affected. And it's really important that we monitor for hyperglycemia frequently, and we manage same with the addition of further medications if required, but also just a caution around when we are tapering steroids that we do continue to monitor the blood sugar levels, because the patient's at risk of hypoglycemia, and that can obviously have an adverse event on the patient. It's generally reversible once you stop the steroid. And same with hypertension, another issue that can be exacerbated. Again, it may require additional treatment with medication. So we need to closely monitor, treat as required. But again, it is a reversible adverse event. So if we start to taper down the dose, we do need to take into consideration that the patient might have a hypotensive event. So we do need to monitor them closely. In terms of cardiovascular risk factors, they're more likely, and it's more common to have a cardiovascular event for people that take steroids. So we need to assess and monitor for those. And just to mention, just significant lower limb edema, that can have a detrimental outcome on older adults, particularly from a functional perspective, but also a mobility, and that can affect their independence. Ocular issues, again, increased risk of glaucoma and cataracts requiring maybe specialist input. Both can impact on visual acuity and can increase patients' risk of slips, falls, and also can have an impact on their quality of life. In terms of peptic ulcer disease, just as I mentioned, I suppose it can be exacerbated by the steroids, and it may require a consideration of commencing the patient on a drug such as a proton pump inhibitor or equivalent to reduce the risk of a gastric ulcer. Myopathy, muscle wastage, again, that can contribute to a decline in function and mobility, and can increase the risk of kind of frailty syndrome. So it is important that we're aware of that. Skin integrity, people on steroids, wound healing will be significantly impaired. Plus, they may already have a pre-existing condition such as diabetes that can also further impair that. So we need to be aware of that, because that can be a big issue where there's wounds involved. In terms of body image, Cushionite symptoms, that can be, that can be quite upsetting for patients, weight gain, and the other effects that it causes. So we need to kind of educate the patient around the signs and symptoms and the strategies to help reduce it, but also, to ensure that there's adherence with their medication, that they don't stop or try to reduce because of those symptoms. And really important, and this is where our pharmacy colleagues come in, is, we need to consider polypharmacy with the addition of ancillary medications with steroids, where we might be adding in drugs for diabetes, hypertension, PPIs, prophylaxis. It increases the risk of drug-to-drug interactions, and we need to be very conscious that we stop and review kind of ancillary medications when they're no longer required, and consider that patients with maybe cognitive impairment, that safety strategies are put in place, but also that we educate the family caregiver or whoever about how to safely manage those medications. So the risk of infection. So patients taking steroids are at an increased risk of infection, because steroids have an immunosuppressant effect. So older adults with functional decline are particularly at an increased risk. The potential for sepsis events may not typically manifest as normal, typical signs of symptoms of infection. So we need to be aware that this can be a consequence of aging, but also the effect of steroids on the body system. They inhibit cytokine release and they reduce inflammation and febrile episodes. So hence thresholds for perimeters for concern may need to be adjusted for older adults, such as, for example, maybe an increase of 1 degree in temperature might indicate an underlying infection, as might requiring more oxygen requirements increase, or a new onset of acute confusion. So just to consider an underlying infection as the source. Patients with cognitive impairment may not have the ability to recognize and report signs and symptoms of infection. So it's really important that we educate the patient, the family caretaker, around the signs and symptoms of infection, and to report them early and to seek medical attention promptly so we can treat them promptly. And then I suppose that, with the immunosuppression with steroids, there is risk of opportunistic infection, so we may need to consider prophylaxis for JP or fungal infections. So here's an example of oral candidiasis. So the risk factors include steroids, immunosuppression, xerostomia, and antibiotics. The consequences are pain, decreased appetite, dysphagia, malnourishment. Frequently assess the oral cavity and ensure the patient removes the dentures for a thorough review. Initiate antifungal therapy as clinically appropriate and pain relief. And we need to educate the patient around oral hygiene, mouthwashes, dental care, and any additional medications. In terms of neuropsychiatric issues, these can be a broad-ranging spectrum. They include anxiety, depression, sleep disturbance, suicidal ideation, memory and concentration difficulty, and rarely mania, severe depression, psychosis. The risk factors are dose-dependent. Higher dose, the greater the risk. Previous history of mental illness, family or personal history, and older age, just I suppose because there's more of a potential to have a cognitive impairment, and female and gender. So these again require assessment and treatment, and some of them can be obviously reversible once we taper down and reduce steroids, and we may need input from psychiatry for older age. Steroid-induced osteoporosis is very important because 1/3 of community dwelling older adults report a fall annually. So bone loss is most common in the first 3 to 6 months, up to the first year really, and they're associated with an increased risk of fracture. So older adults are more likely to have pre-existing bone density issues such as osteopenia and osteoporosis. So baseline assessment is essential for the risk factors, DEXA scan if available, and a FRAC score if clinically appropriate. Some general guidelines around reducing the risk of steroid-induced osteoporosis includes a calcium vitamin D supplement, plus or minus a biphosphate therapy, depending on the patient's risk factors, falls assessment and falls prevention education, diet and exercise, particularly weight-bearing exercise, lifestyle, stop smoking, limit alcohol, and consider referrals to the physiotherapist and the occupational therapist also. Additional supportive care measures then include, ensure that we do at baseline and as indicated, frequently as indicated, height, weight, blood pressure, blood glucose level monitorings. We need to consider the use of a proton pump inhibitor or equivalent for especially those of high risk of gastritis and gastric ulcers, such as those on non-steroidal anti-inflammatories and anticoagulants. Consider prophylaxis for prophylaxis, antifungal prophylaxis, and varicella zoster prophylaxis. And I suppose patients that would not have had chickenpox in the past need to be advised that if they do come into contact with somebody, that they need to seek urgent medical attention. Ocular examination, particularly intraocular pressure checks for patients that are on steroids more than 6 weeks, monitor bloods, and then there's other screenings that we can do: chest x-rays, bone density scans, HPS access suppression for the adrenals, and occult blood loss. And then just finally, it's really important that we could, we do a thorough baseline assessment for all patients commencing steroids. And as Darren mentioned, particularly input from other disciplines. We monitor patients for adverse events quite closely. We use the lowest dose for the shortest period of time to achieve the clinical goal, but that doesn't mean that we can't use high doses. Sometimes high doses are very appropriate and necessary. Likewise, we don't want to taper down steroids too quickly in case we risk a rebound in the inflammatory event, or it affects the patient's outcomes. So we need to use a clinical decision here. And it's very important that we stop any ancillary medications that are no longer required. Education and support for the patient and the caregiver is absolutely essential. And I suppose just, is there a need for more robust guidelines on the use of high dose steroids in the management of older adults that have had immune-related adverse events? So thank you.
Thank you, Michelle, and thanks everyone for your excellent talks. I realize we are at time already, so maybe we have one question in the chat for the panel about immune checkpoint inhibitors was better than chemo and in quality of life in the OAK study, which was positive for overall survivor. Do we have the same results in negative studies of chemo versus immune checkpoint inhibitors? In other words, is improved quality of life mainly effect of cancer control or toxicity profile?
I'll probably address that one. Yeah, so often negative trials, they don't end up publishing their quality of life data, so that's an issue, and often we don't get all of the data set. And even the positive ones, there's been more of a recent trend for us to get the quality of life data, because even before, although it was part of the secondary aims, not always we would get that. So I would say that the vast majority probably we don't really have that data. But then the other part of the question maybe is around, do we see that the quality of life improves? Is it because actually the treatment is working and not a matter of side effects? So I think it's very helpful when we look at the graphs that are showing not the time to deterioration necessarily, but seeing the variability from the baseline quality of life over time. So these are patients that are on treatment. So if they're on treatment, that means the treatment was at least helping. And on those patients, I think it's quite obvious, and it's quite a so we see that same result across multiple trials, that we can see that improvement with the quality of life on the immunotherapy that we don't see necessarily with the chemotherapy. So I would say, and I think we all have that experience as well, that usually at least single agent immunotherapy tends to be very well tolerated. So I would say that it is probably a mix of both, but it's primarily because it's the tolerability makes a big difference.
Thank you, Fabio. And then I would like to thank all of you again for this excellent webinar, and thank everyone for joining our webinar. It will be uploaded to the Young SIOG and Nursing Allied Health website for everyone to review later. And I think there are no more questions in the chat, but I'm sure if you have additional speakers, if you email the participants, or if you want to email me and I can connect you with the participants, I'm sure they would be more than happy to answer any additional questions. So thank you all for joining us today. If anyone of you who was on the webinar today has any ideas what you would like to hear in future webinars, or if you have something that would be of interest to Young SIOG and Nursing Allied Health, please email Fabio and me, because we would love to do more webinars and make sure that it addresses needs that you all have.
Thanks, Martine. I was just having a quick look that I think Dan was answering the question that was on the Q&A, wasn't it?
Oh, sorry, did I miss anything?
Yeah, there was a different window, but
oh, sorry.
You know, given we're out of time, I just typed a super brief, somewhat cryptic response to it.
Okay, thank you so much. I missed that one, but thank you all very much. And then we will send you an email so that you all know that the webinar recording is uploaded, in case questions come.
Thank you all.
Thank you.
Thank you. Have a lovely evening, afternoon, morning.
You too.
Everyone.